Thank you very much, Amar, for having me for this course. I'll be talking about certain extreme situations wherein phaco is a problem. Now, normally big troubles come in small packages, and that is what I'm going to talk about. Nanophthalmos. If you're looking at a small eye, by definition, a nanophthalmos is an eye which is less than about 20 millimeters, and it poses certain challenges. The challenges with nanophthalmos are that it's a short axial length, the corneas are small, the AC is shallow, and there is a marked iris convexity. The lens is disproportionately thicker to the overall volume of the eye, and it is known to cause uveal effusions, and thickened sclera and choroid is one of the reasons. Now, an anophthalmic eye is also usually highly hyperopic and is deep set orbits, and therefore it is subject to shallow interior chamber. So this also has a propensity for iris prolapse and chaffing, and lens power calculation is often a problem. So ideally you could do it under a block, but if you want you could do it under topical. If the pressure is high, you need to give intravenous mannitol before. Use good viscoelastic, and the risk of posterior capsular rupture is definitely increased because of the floppy and thin capsules, the weak zonules, and positive posterior pressure, and you might need to suture the wound because of hypotony. So let me show you a case of a nanophthalmos. Can you dim the lights, please? Now this is an anophthalmic eye, one-eyed patient, and the femto failed me in all these dimensions. So let us look at what the femto does. The first problem is that I needed to try and dock the eye being small, the orbit being shallow. It took me 3-4 attempts to dock the eye. And once I have docked the eye, you can see that the iris is not pretty good, it's small. I am just putting the side port here. And then you can see that I have centered the capsulotomy and the nucleus fractionation. Now what happens under these circumstances is that once you have centered, you have to see that this thing does not touch the iris. So you have to have a clear zone, or you could reduce the fractionation area. So I thought things would be good. And when I get the OCT image, what you see is that this is the anterior capsule, and because the eye is small, the default is such that the anterior and the posterior capsule lines are coming way below the anterior capsule. And I go up, it comes down. I go up, it comes down. So essentially what's happening is that the default for the eye is such that because the eye is small, you are not able to even focus the anterior capsule of the system onto the anterior capsule, because these two lines has to be within the anterior capsule. So I tried 2-3 times, 4 times. I again dock, but really it does not come through. So I have to abort the procedure. I have to go away from using femto assisted in this eye where I wanted to. So that's my first failure. That's the first challenging situation that I had. So now I go in. We have given a block to the patient, and I go ahead and do a capsulotomy. Now the moment I am doing a capsulotomy, as I told you, this is typical of a nanophthalmic eye. The chamber is shallow. We are losing the chamber. And you can see that the iris is tending to prolapse out, even though it's a lady patient, no question of tamsulosin or anything, but this is a typical situation where you have an iris prolapse, as you can see here, and progressive shallowing of the anterior chamber. So this is, you go ahead, you do a capsulotomy, which takes a little while, and after doing this particular situation, we can go ahead, and the phacoemulsification really goes on, but you have to take all the precautions in phacoemulsification so that you don't end up with a problem. Look at that iris coming out again and again, and you can see that we're doing a hydrodissection in this particular case, and there you do the phacoemulsification, and things get out reasonably well because it's a shallow anterior chamber. Now, epinucleus plate coming out, we go ahead and we finish this particular case. Now the problem is I got a special lens made for this patient to the power of 55 diopters. So the first thing that happens is that I try to fold the lens and it would not fit into the injector system. That means that it was so huge that the injector system, it would not fit into that. and because I didn't have a spare lens, so what I did is that I enlarged the incision and tried to put it like a PMMA lens, but since it's a foldable lens, it is a problem, so we have to enlarge the incision further, and we do this. Now the next problem that comes in is, you can see how thick the lens is. Can you see? Plus 55. So maybe it would have been a better idea to do a piggyback IOL of 2 regular lenses rather than having a specifically made 55-56 diopter lens. And then what happens is, because of the volume of the lens is so high, the haptic which is here does not go into the bag. And I try and it does not go into the bag. And ultimately, what I think I center, you can see that it's not gone into the bag. And I'm again trying and going into it, and it is still not going. And there is a laxity of the capsule that I'm observing. And I just leave it at this, center it. And I have to now, because of the incision also, I have to put a suture. So these are the problems that I had. And post-operatively, when I see this patient today, one haptic is still in the capsular, is in the bag, and the other one is not in the bag. So better idea is, the take-home messages are that you have several problems that you have in an anophthalmic eye. An anophthalmic eye will not be commensurate until, of course, the default setting are changed with a femtosecond laser. And from a surgery perspective, I have given you the key hints, and it is better to go in for a piggyback IOL rather than get a specifically manufactured 57 lens which is there. Now the next thing is, let me show you a patient who had been fixed up for a glued IOL. You can see in this particular case, this is bullous keratopathy that is there. You can see that it's a badly performed surgery. There's a rent and the lens is just lying there. So we go ahead and remove the epithelium, as you can see, so that the visualization is better. The corneal, the scleral flaps have been made. You go in with this particular, do the vitrectomy, and then you exteriorize the haptics. So what we are trying to do is that the same posterior chamber intraocular lens, if the PCR which was having a problem, we are trying to fixate that particular same lens which is here. So we go ahead and remove the haptics. As you can see, they have been exteriorized. Similarly, this one haptic was on the iris. You are pulling out the haptic, as you can see, from the iris and holding it, and then you are pulling it out. So once you have the glued IOL that has been finished, the next step is obviously to retrieve the cornea. So from the cornea perspective, we will be doing what is called as a DASIC, and in this you can see we have put pilocarpine, and we make a side port for pulling the lenticle, and you can see that we have pulled the lenticle. Now we are putting air, but observe what is happening. The lenticle is tending to come out. You push air, the air is not staying in, and the lenticle is tending to come out again and again. So what we do is that we go ahead and put a suture in this particular case as to why is the lenticle. See, that's an expulsion of the lenticle. The lenticle is tending to come out. We again hold the lenticle and again pull it back into the eye. And the infusion is off, but despite the infusion off, you can see that the lenticle is still on its way out. So we put air. Once we have put air, we try to then put the sutures, and post-operatively we observed that there was hemorrhage. Somehow we got out of it, but then this patient actually had a bleed, a suprachoroidal bleed, and this is what we do after about a couple of days, in less than a week's time, and you can see that this is a drainage that is being done. So we are doing a sclerotomy, and look at this. Look at this. So this was the reason. It was an undetected suprachoroidal that hemorrhage, and hemorrhage, it didn't go into a frank expulsive hemorrhage, but we did not recognize on the table. Had it been recognized on the table, one would have been able to kind of get a better outcome in this particular case. So you can see that there is the suprachoroidals that have been drained, and after that a suture, and this is the next and last situation that we are talking about. Now, whenever you have a small pupil, you use iris hooks or you use a Malugan ring, and you can see this is a Malugan ring that we are going to use in this particular case. We go ahead, put viscoelastic, and you can see that this is the Malugan ring that's being, and here you go, the first part, there are four parts to make the whole Malugan ring expand the pupil. So the first one has engaged the iris. These are the other two areas or the rings which need to be engaged in this, and you can see that this is now opening, and this goes in, you open, and because it's again a hyperopic and a small eye, and you can see it's a mature cataract, putting in a Malugan ring is giving us some problem. Now we go ahead, use the second hand. This is the iris hook that we have. We go ahead and use this, and there we are. We can put in the Malugan ring which is there, and we go, this gets completed. Now, after the cataract surgery has been done, this is an Acryos AO lens that is being used, and pupil is still not very big, the space is not there, and we are trying to put the intraocular lens in. Now what happens is that at this ring juncture, the plate haptic or the foot of the Acryos gets stuck there. So you have this problem that we are not able to put the intraocular lens into the eye. One would never expect this kind of a problem, but these are small problems which do happen. Now you are really stuck because these two are stuck and it is not willing to go into the capsular bag. Now what do you do in such a situation? So what we try to do is we nudge the ring around, we try to see whether it's going to help or not, and then we decide to explant the ring. Now as we are explanting the ring, there you can see that the lens is moving along with it, so the whole thing has become one complex. So it's we are not able to even get out the ring. So what we do is the Malugan ring is cut, and then when you go, you try to rotate it out, and you see that the Malugan ring is then coming out here. And now we can go ahead and put in the intraocular lens. So this was again a situation which was not expected. A surgeon had the Adeline high, putting in the ring, doing the phacoemulsification and getting the things, but putting in a lens, I showed you a nanophthalmic eye with a 57 diopter lens, which was a problem. Now in this particular case, a normal thing, and this also causing a problem. So this is what I wanted to show. Amar, how's on time?
2 minutes.
Huh?
2 minutes.
Yeah, okay. So this is I'll just show you one which is not something which went perfectly, and this is a case of a DSEC, a glued IOL, along with an explant that is there. So you see in this particular case, there is an anterior chamber lens that was put 14 years ago, and after 14 years, the cornea started to decompensate. So what is the option that you have? So we go ahead, make a scleral incision because it's a PMML lens. We remove the lens, and you can see that there are adhesions there. So when you're looking at adhesions, you need to be careful to gently remove these adhesions. We have removed the adhesions, and now we have pulled out the Kelman multiplex anterior chamber lens. Now this is a Malugan ring again that's being used. So you can see we are putting this Malugan ring to give you an adequate exposure of the field so that you can go ahead and do a glued IOL. So this is the Malugan ring that has been put. We do the vitrectomy, and then we go ahead. This is a lens that we are using, a 3-piece lens, which is a typical lens that we have to use for gluing an intraocular lens. We push it into the eye, and then we go ahead and do the glued eye. It's the technique. You can see that the haptic has been exteriorized from one side. That's the haptic that's being held by the assistant on the left side, and then you have the second haptic that has been withdrawn. Now once you have the haptics out, you go ahead and make this scleral tunnel and push the haptics in. Now you want a small pupil for DSEC. So you don't want a large pupil, so you're withdrawing the Malyugin ring, as you can see here. In this particular, there is no problem. And then we have the Busan glide that we are using, and the pull technique from the other side to put in the lenticle for the DSEC procedure. We put air, and you can see that there is a decentration of the lenticle. Can you see that? So we just use a reverse Sinskey and pull it back and push in the lenticle to the right place. So this is the glue that is being applied, and we are ending up with a very good post-operative result in this particular case. See this patient, and this is day 1 post-op, 1 week post-op, 3 weeks post-op, and you can see on the OCT the DSEC that is there. So friends, all that I showed you in these are that there are small little unexpected things when it is not your day which happens, but these are things which I did not anticipate, and since we had a recording of them, I just wanted to share it with you so that you are wiser and learn from somebody else's mistake. Thank you very much for your kind attention.